To start by thanking everybody for coming. We're really excited about this webinar on the lifelong needs of simple congenital heart defects. I want to thank the International Society of Adult Congenital Heart Disease and Heart University for co-sponsoring this event. And it's also hosted by the Global Alliance for Rheumatic and Congenital Heart and Children's Heart Link. I want to begin with an introduction to those two organizations briefly, and then we'll move on to introducing the panelists and the webinars itself.
You may know our organizations. This webinar is co-hosted by Global Arch and Children's Heart Link. Children's Heart Link is a global NGO based in Minnesota and Minneapolis, Minnesota. We are actually in partnership with Global Arch, starting to do a lot of education and awareness around lifelong care of patients, for patients with childhood onset heart disease, which includes congenital heart disease and rheumatic heart disease. Our organization is focused on otherwise building capacity and advocating for pediatric cardiac services globally, and have been in existence for over 50 years. So we're really happy to have you here. I'm sure some of you know us from our work globally, and some of you know us from our work in partnership with Global Arch. So I'll let Amy speak a little bit about Global Arch as well.
Thank you so much, Bistra. Global Arch, or the Global Alliance for Rheumatic and Congenital Heart, is an organization. It's an alliance of organizations, primarily patient and family organizations from around the world. Currently, we have over 60 group members in 45 countries, and more than half of them are in low and middle income countries. It's free and open to all, and I encourage you, if you're part of an organization, to join after this call. We were founded based on a deep belief that a key part of solving the problem of how to overcome global inequity in CHD care is through empowering these patient and family organizations. So our mission is to improve worldwide lifelong outcomes in childhood onset heart disease through empowering patient and family organizations. And as Bistra noted, we're partnering now with thinking about how do we think in the long term to make sure that all these children have a future as we move forward with developing these programs. So thank you, Katie. Next, I want to introduce our speakers. So our first speaker will be Dr. Sasha Opatowski. He's the professor of pediatrics and the director of Cincinnati Children's Adult Congenital Heart Program, which is a co-project of the Cincinnati Children's Heart Hospital and the University of Cincinnati. After that, we will hear from Dr. Navanita Sasikumar. She's an associate professor of cardiology at Amrita Institute of Medical Sciences, which is in Kerala, India. And then we will have a moderated panel with two panelists. That is Dr. Babar Hassan, who's a professor of cardiology and the chair of the Division of Cardiothoracic Sciences at the Sindh Institute of Urology and Transplantation, which is in Karachi, Pakistan. And Dr. Francis Finn Thompson, who is a pediatric cardiac surgeon at Boston Children's Hospital. And he also runs an organization called Hearts and Minds of Ghana, which is a humanitarian group that has run 11 surgical missions in Ghana. So thank you so much to all our panelists. And if Dr. Opatowski, if you could begin.
Hello, thank you so much for inviting me. It's really exciting to be here with an incredible organization that has really emerged over the last pretty short period of time to really have a huge impact, and with panelists and others who I've known for a long time. It's pretty exciting to be here, and I think the topic is one that is often overlooked. So I'm really grateful that we're speaking about it. And that is to speak about simple congenital heart disease. And my task is to talk a bit about what we know about long-term risks of simple CHD. So in the end, I'll come back to this. The upshot is that simple doesn't mean necessarily mild. It definitely doesn't mean no risk. And it doesn't necessarily imply high risk, of course. Most individuals with simple CHD do well, but simple CHD is associated with increased risk and meaningfully increased risk of adverse outcomes, even in the context of successful early repair. Expertise and experience is needed to identify, prevent, and mitigate complications. And while it's not realistic or desirable for ACHD specialists to care for all simple CHD, and that's even in the most resourced environments, at least all CHD, including simple CHD, should be seen at least once. And then systematic relationships with patients and community providers can continue to maintain that linked expertise. So perhaps the first post-surgical patient who was lost to follow-up because she was simple and cured was the first patient who underwent a cardiovascular surgery. And Dr. Finn Thompson, I will not associate you with this comment, but I will associate you with this amazing pioneering event at your institution. And this is Ms. Sweeney, Lorraine Sweeney, who was the first patient to have a cardiovascular surgery at Boston Children's, which was a PDA closure. She was lost to follow-up, or maybe discharged from follow-up, but then she became pregnant, and then her obstetrician called Dr. Gross, the surgeon, to ask about complications due to the pregnancy. And Dr. Gross assured her that both Sweeney and her heart were perfectly healthy. And I think this is not the first or last instance of a surgeon being quite confident and an obstetrician being quite worried and a patient coming back into ACHD care because of obstetrics. But even from the get-go, there was an impression that simple defects were cured and there was no associated risk. I'll tell a quick story about a patient who came back into care here in Cincinnati, maybe 1.5, 2 years ago. She's one of the patients pictured in this photograph. She's a patient who had open heart surgery with bypass back in the 1950s, so she was one of the first. She had a VSD closed, and she was referred back from a community cardiologist. She hadn't been seen in probably 50 years at least. And he had noticed that she had elevated pulmonary artery pressures and referred her to us for evaluation of pulmonary hypertension. Echocardiogram showed that she actually had some muscle bundles in her RV outflow tract. So more likely she had mild double chamber right ventricle. So that was favorable. But she did have atrial tachycardia. And it turns out those weren't even her biggest issues. So she came into clinic. We cured her of one issue she didn't have. We found one other that she did have. But in truth, her biggest issue is she had terrible PTSD from her initial experiences. And she was under 10 years old. She remembers everybody being very kind. She remembers her first cardiologist, Sam Kaplan, who she thought was an amazingly lovely person. Her parents were very supportive. Everything went well. And yet for the next 50 years, her medical care was always impacted by the fact that she really couldn't hear what doctors were saying, couldn't remember, was shaking by the time she left the hospital. And a lot of her care really had been trying to address the PTSD that related to her early experiences. And I just want to emphasize that as we're talking from a country that has a lot of resources to nations that don't necessarily have a lot of resources, I think we're not at all suggesting we know what to do, because I think all we do know is that we've made a lot of mistakes and not followed a lot of these patients and found a lot that have come back into care in a place that would have been better off being discovered a while back. So we've already made a mistake, and we're trying to address that. And it's not that easy once we've lost a lot of these patients and their information to understand how to identify them and keep in touch and make sure that we are communicating with the system to make sure that they get appropriate care. What don't we mean by simple congenital heart disease? When we're talking about simple to complex, I think it may have been a terminology that is a bit too easy to misunderstand. We're not really talking about low risk to high risk. We're talking about simple anatomy to complex anatomy. And while there is some relationship between risk and complexity, there is more distinction, and it would be best not to think of them in these terms. And if we go back to how this came about, this simple to complex distinction, it came about in the 1996 Canadian Society guidelines, which were then adopted in the Bethesda conference in the early 2000s. And they identified certain types of patients with simple congenital heart disease. And the way this was thought of is that these were patients that can usually be cared for in the general medical community. You'll see in a second that they didn't mean that these patients should not have ACHD care at all or relationships, but rather that most of their care could be delivered in the general medical community. And here's a list of some of those diagnoses that were listed. And what you can see more recently is there is some distinction about what is defined as simple CHD. In the American guidelines from 2018, bicuspid valve and isolated congenital aortic valve disease is included as moderate, while in the European guidelines, that's mild. Isolated congenital mitral valve disease, likewise in the American guidelines, is considered moderate, while European guidelines is mild. So definitions vary, but interestingly, there's really decades of consensus about what to do about simple congenital heart disease in a way that it doesn't really matter that our exact definitions may vary a little bit, and that is whether a patient's simple, moderate, or severely complex. And I should go back 1 second. The Europeans, I think, wisely changed from simple to mild in terms of how they classify these diagnoses. As you'll see in a second, the Americans did something else. But there's decades of consensus that every ACHD patient should be evaluated at least once by an ACHD cardiologist, even for so-called simple congenital heart disease, with a goal to ensure that other diagnoses or subtle but important findings have not been missed. And that includes both physical and psychological impacts of congenital heart disease. And too often patients with simple congenital heart disease are seen who have been misdiagnosed, mismanaged, or misinformed. And I think that all of us have experiences that show that to be the case. So that document was from 2001, and these are the more recent guidelines, the upshot of which is that most, if not all, patients with even simple congenital heart disease should be seen at least once and managed in collaboration with ACHD specialists. So where does this idea that simple equals no risk or simple equals low risk, where does that come from? And I have to admit, and I know this is being recorded, so I hope nobody watches this, but I have to say I had this misconception, and reading through the guidelines again and the data for this presentation reiterated to me that this misconception, while I've disabused myself of it a few times, it keeps coming back. And it comes from a few papers in the earlier days of adult congenital heart disease that have, I think, been misinterpreted, understandably so. But this is one example, an excellent paper from the Mayo Clinic talking about long-term outcome after ASD. This was from 1990, follow-up of about 30 years. And this is where the idea that if someone had an ASD closed before the age of 25, they basically had no increased risk. Well, what was actually noted was that there was no appreciably or statistically significant difference in long-term survival from that of a control population. And what you can see for the 12 to 24-year-olds up here, of whom there were only 29, the mortality for those who had an ASD closed was 7%, while for those in the general population, it was 3%. Now, 3% versus 7% mortality is actually quite different, but with this sample size, they couldn't distinguish those two numbers. So this paper shouldn't be taken to mean there's no difference in mortality, and it certainly shouldn't be taken to mean that there's no difference in comorbidities or adverse outcomes. As you can see here, even with this small sample size of only 62 patients less than 25 years old, 2 of those had heart failure, 2 had a permanent pacemaker, 2 needed operations, 2 had endocarditis. And this is among patients who were under 50 years old, generally at the time of follow-up. So this is a substantial comorbidity. And you can see that the number of patients who had AFib or AFlutter, which are not included in this late cardiac event, was quite high in those who had surgery, even in the 12 to 24 age. Here's a paper more recently using larger data sets, in this case from, I believe it was Denmark, that basically sort of went back, and again, I think may not have dug as deeply, because looking back at the earlier papers, very few people were really suggesting that simple congenital heart disease was truly benign. They do reiterate that in 1998, the Canadian Cardiovascular Society published their 1996 guidelines, which recommended that patients with simple CHD could be cared for in the community primarily, but that didn't mean that they shouldn't have some ACHD connection and some relationship established with a visit. And then they also reiterated what I think is the misconception that the benign prognosis of simple CHDs was supported by several studies with patient follow-up for up to 35 years. Again, reading those papers, while that's true, it depends what you mean by benign prognosis. And there were cautions in each of those papers. So this is that work from Denmark. And what you can see is that there is increased mortality, and this is for all simple congenital heart disease. In this case, they define that as ASD, PDA, pulmonary stenosis, mild pulmonary stenosis without surgery, or a VSD. And there's increased risk in any of these cohorts. It didn't matter whether you were born in the 50s or 60s or early 70s. This may or may not apply to patients that are younger, but probably there is some risk. So there's an increase in mortality, but what you can see here is that the absolute risk of mortality is still not markedly elevated. And there was also an increased risk of morbidity of a whole bunch of types. I don't show that here, but that from anything from endocarditis to atrial arrhythmias, et cetera. And in that case, up to 20% of patients by the age of 55 did have some adverse outcome or comorbidity. So it's substantial, but a lot of these are mild. So there's a meaningful increase even with simple congenital heart disease. But it's important to reiterate, because there has been a bit of overreaction to that higher risk doesn't mean high risk. We shouldn't be alarmist. Most of these patients do quite well. And with sophisticated testing and larger data sets, we do start to identify subtle abnormalities and modest risks. And truthfully, because a lot of these data sets are not made thinking ahead of time about our patients, there are also false associations that can come out. Nevertheless, there is a sizable minority that develop meaningful comorbidities and experience adverse outcomes, and really importantly, that are best diagnosed and treated by a specialty trained, knowledgeable clinician. So why is it that we should care for simple CHD when we're overworked already with the more complex congenital heart disease? I was very excited to see our Fontan nurse manager, the wonderful Felicia Eichelbrenner, join us. And she works with some of our most complex patients, but it's also really important that we think about our simple patients. Part of that is that there's increased risk. The second is that those risks are often overlooked without extensive CHD experience, things like double chamber right ventricle. And even that applies even to superb general cardiologists. In the same way that I'm not necessarily going to be the best person to manage run-of-the-mill atrial fibrillation, just because it's not something I do every day. A superb general cardiologist doesn't manage congenital heart disease every day. And I find at least that it's some of the most gratifying work we do, and the impact and yield of our expertise and experience is often greatest, because a lot of this can be addressed in a really substantial way, such even if it's not cured, it makes a major difference in the patient's life with relatively little risk in terms of the intervention. It's also important because our understanding changes of the impacts of congenital heart disease, and the long-term outlook is often unknown. Reading some of these papers about ASD and VSD closure, I was reminded of the early experience with, say, Ivalon patches, which were quickly discovered to deteriorate and cause major issues. But that wasn't known at the very beginning. And a lot of the adverse effects of some of the things we do are not going to be known for 10, 20, 30 years. So for a lot of our device closures, we often will discharge a patient. The truth is, we really don't know what the outcome is 30 or 40 years down the line, well, at all. It's also important to note that the meaning to the patient evolves over time and context. An obvious example is heritability in pregnancy. That may not matter to someone at the age of 15 or 20 when they're discharged from care, if they are, but might matter at the age of 30. So reiterating to them that they have a connection to their doctors, that there is a resource for this, is important. It's also critical that many of the impacts of congenital heart disease, including psychological, but not only, correlate minimally with anatomy. Patients interpret their experience with their disease quite distinctly from how severe or complex the underlying disease is. So again, the upshot, it's simple should not be taken to imply mild or no risk, but it also shouldn't mean these patients are all at high risk. Patients should be reassured that most individuals with simple CHD do well, but simple CHD is associated with increased risk of adverse outcomes even after successful repair, that our expertise is needed to identify and prevent and mitigate complications. And while it's not realistic or desirable for ACHD specialists to give the primary care for all simple CHD, nevertheless, all CHD should be seen at least once, and that something that we don't always do that well in any environment, including in the United States, developing that systematic relationship with those patients and our community providers is critical to allowing us to follow these patients from an arm's length. And for hope, here's a picture of Lorraine Sweeney in her 80s. As you can see very well a major complication of having surgery at Boston Children's Hospital is having an affiliation with the Boston Red Sox, but there's nothing that we can do about that. Thank you very much.
Thank you. Thank you so much, Dr. Apatowski. I want to note that people, you can put questions in the chat. We will have Q&A, and we also will get back to questions that we can't get to in this session. And also, I want to note that follow up on Beester's comment that we encourage people, if you can, to introduce yourself in the chat bar. Our next speaker is Dr. Sasikumar from India, and if you could go ahead and share your slides, that would be great.
Hello, good morning, everyone. I hope I'm audible and my slides are visible.
Yes, you're all good.
Okay, thank you, Amy. My sincere thanks to Amy and Katie and all these support staff from Global Arc, Bistra, Veera, and everyone from Children's Heartlink, the organizers and supporters of this wonderful session. So in the next few minutes, I will be sharing a couple of cases from our experience at Amita Institute, Kochi, regarding a follow-up of simple congenital heart diseases. So when Amy first told us about this session and the context of it, we tried to get a case that would best fit in the descriptions that we were having, like somebody with an operated simple congenital heart disease, like a ventricular or an atrial septal defect or a patent rectus arteriosus, who was lost to follow up and came back with a major issue. And for various reasons, which we presume, which we can discuss in the discussion, we couldn't find one that would exactly fit into it, but of course we have a good number of illustrative cases which can show that although by name it would be simple, and after the first surgery the family or even the primary care providers may think that everything is all right and they do not need further follow-up. Most of them will benefit from at least a couple of times follow-up with their congenital heart disease specialists after their surgeries in the initial years, and then of course at least at some infrequent intervals later, depending on how the first few visits went and how their hearts are after the surgery on the initial follow-up. So without further descriptions, I'll go into the clinical scenario one. So this is a story of a gentleman who was 23 years old currently. He first presented at 3 months of age, which was in 2000, as an infant with congestive heart failure. He was identified to have a large VSD, which was in the muscular septum. It was extending all the way to the apex. He also had a patent rectus arteriosus. VSD closure was contemplated because of technical challenges in closing a huge VSD in a small child. He underwent PA banding, which is a palliative procedure, and PDA ligation in the year 2000. After that, he was lost to follow up for almost 16 years. So after the band, the CHF, the heart failure symptoms improved, the baby was gaining weight. They came for one follow-up after the surgery, and after that, as the baby was doing well, the family presumed that everything was well, and for 16 years, he was lost to follow up with us. And then it was in 2016, at the age of 16 years, that he presented again. And interestingly enough, what happened was that he was referred to hematology for evaluation of polycythemia, and it was hematology that in our own hospital that referred the patient to the pediatric cardiology department. So by the age of 16 years, the band that was placed when he was an infant had become very tight. The ventricular septal defects was trending bidirectional, and he had a systemic saturation of around 90 to 92%. I have some echo pictures here which demonstrates the large mid-muscular VSD, and you can appreciate that there is a significant ventricular dysfunction. The short axis view demonstrates the ventricular dysfunction better. We can see that it is severe, and the large VSD can also be appreciated here. So this is a gradient of continuous wave Doppler across the band, which shows a significant and significantly tight band as well. So after discussions, he underwent PA debanding, VSD and AFC closure in 2016 at 16 years of age. Given the general condition, including the ventricular dysfunction, as well as a very long-standing band, he had a very stormy post-operative course with ectopic atrial tachycardia, ventricular dysfunction, low cardiac output state, and the prolonged ICU and hospital stay. At the end of it, he was discharged in sinus rhythm at a 22-day hospital stay for the surgery. In 2017, a year after the surgery, he was admitted for unrelated issue. That is, he was diagnosed to have dengue fever. At that time, multiple atrial ectopics were noted on his ECG. A Holter monitoring study was done on follow-up in 2017, which showed short runs of ectopic atrial tachycardia. Later, in 2022, at 22 years of age, he presented with pre-syncopal episodes, and he was found to have atrial fibrillation at fast ventricular rate. His rate was controlled and was started on anticoagulation and planned for elective cardioversion. Despite initial anticoagulation, he had a clot in the right atrium, and the anticoagulation, and the cardioversion couldn't be carried on at that setting, and he was discharged on warfarin and sotalol for weight control. In April 2023, 23 years of age, he was on follow-up intermittently, and his weight was well controlled despite being on sotalol, which can sometimes help in converting into sinus rhythm as well. He continued to be in atrial fibrillation, and we scheduled him for one more attempt at cardioversion. So this time there was no clot. We cardioverted him and reverted to sinus, which is normal rhythm. But unfortunately, he went back to atrial fibrillation the next day. They're quite understandable in the sense that he still has some ventricular dysfunction and his chambers are dilated. We decided to continue him on medication. He's currently functional class 1 with a well-controlled rate. He works as an associate director in the Kerala film industry. So this is the ECG at discharge, where we can, there is atrial fibrillation still, but the weight is well controlled. And his ventricular function is much better than the preoperative state. The short axis shows slightly better, but he still has mild ventricular dysfunction. So this is the first case And I will go to the second case, which is a short one, and which actually is of a child on follow-up, not an adult. But we felt that it has an important message, although maybe a rare happening. So the second patient is currently a 10-year-old girl. Again, her first presentation was as a few months old with congestive heart failure. And she was also found to have a large VSD and an ASD, and she underwent a surgical closure of the defect at 6 months of age. That was in 2013. And she was again well post-operatively and was on follow-up elsewhere in the community. And in 2018, 5 years after the surgical closure, she was referred for evaluation when she presented with effort intolerance, palpitations, and epistaxis. So her clinical examination was unremarkable except for a loud T2, a palpable T2, which indicates significant pulmonary hypertension. On echocardiograms, the right heart was enlarged. There was severe pulmonary hypertension with systemic right ventricular pressure. And there was right ventricular dysfunction as well. So, so in this particular case, we thought that the congenital heart disease was repaired at a reasonably appropriate age of 6 months, and we thought, and the initial echoes did not have residual pulmonary hypertension. And hence, she underwent thorough evaluation as part of her pulmonary hypertension workup, including HRCT chest, CT pulmonary angiogram to rule out pulmonary embolism, blood work to look for rheumatic or connective tissue disorders, which could contribute to pulmonary hypertension. But all of them came back negative, and we suggested genetic evaluation for her for pulmonary hypertension. And the BMTR2 mutation came positive for her. This is known to be a mutation associated with familial pulmonary artery hypertension. Family screen and echocardiography was done for her parents and siblings. None of them had pulmonary hypertension. Genetic screening was suggested for the family, but they have not undergone it as of now. As known, despite being on dual therapy, which is ambrisentan and tadalafil, she still continues to have class 2 symptoms and occasional pre-syncope as well. It is known that this particular mutation associated with pulmonary hypertension, such patients have early onset and more severe disease, and they do not respond well to pulmonary vasodilator therapy compared to patients who do not have the mutation. So these were the two cases, both of them having VSD. The first one palliated but lost to follow-up and all the issues that followed that, and he still needs close follow-up with a specialist. The second one corrected, but unfortunately it developed pulmonary hypertension, which is unrelated to the congenital heart disease. And that, both the cases, beautifully demonstrate how it all boils down to a proper communication regarding the patient's condition, and educating and empowering the families, the cause for which we all are here together today. Thank you for your patient listening.
Thank you. That was very excellent. I want to say both the talks were just a wonderful introduction to our conversation. So I wanted to now encourage our two panelists, who are Dr. Finn Thompson and Dr. Hassan, to first just, what are your comments about what has been presented so far initially? Any initial thoughts?
Francis, you can go ahead, and then I can speak.
Yeah, thank you. No, both excellent presentations, and I think give you a scope of the problem, obviously, that exists, particularly in parts of the world that are really resource constrained in terms of being able to provide care. I want to give you, though, I'll make perhaps a different perspective, a surgeon's perspective, and a different cohort of patients. So I think a number of the patients that were discussed are patients who at some point early in their life did have access to either palliation or corrective surgery, and then still one has to manage the long-term consequence of their simple disease. But what I often find, what we always struggle with is, in fact, adult patients with simple lesions that haven't been corrected or palliated, if that's the if their simple lesion could be palliated. And what I find as a surgeon is that the surgical management of those patients by the time they're adults is vastly different. There's a different set of issues that one has to consider. The operations are carry a different risk profile than they might have when the patients were much younger. So as an example, you know, even a simple VSD that went either unrecognized, uncorrected, or the patient simply had no access to congenital care might present later in life with significant aortic regurgitation. So a lesion that might have avoided that aortic regurgitation later in life now becomes a much more complicated repair. And so I think that that's certainly another cohort of patients that I think it's worth discussing, because it does require both a different surgical expertise, expectation of what that patient will need, but also I think has different implications for how that patient might be managed by our cardiology colleagues. So I just wanted to make that comment.
Thank you very much. That's a really important comment. Also, obviously, since that's a patient population which you see in low resource settings, which we really don't see anymore in high income countries. Dr. Hassan?
Yeah, so I would definitely echo what Francis just said. And I think that's, some of the data, if you look at the IQIC, which is the International Quality Improvement Collaborative data, what you will see is that nearly 20% or more than those 20 to 25% of patient volume that you'll see are actually adult congenital heart disease patients who are unrepaired in the surgical programs. And I think what's also important is, and especially when you see countries where the surgical services or the congenital heart disease services are not that well established, and their surgical care is predominantly mission surgical care driven, that, you know, some of these quote unquote simple lesions are not thought through in detail, because a simple ASD that is in an older patient is not just a defect or a hole that needs to be closed. You know, one has to really think it through and understand what it is. It needs to have the proper evaluation done. Similarly, for example, you know, a simple unrepaired late presenting VSD is not as simple as we think it is. And I think one has to really understand what these patients can do, because again, if the message goes that, oh, this is a simple defect, we have closed it, and, you know, and everything is hunky-dory, what you're going to see is patients who will present with post-operative pulmonary hypertension. And in fact, I see quite a bit of these, and patients in my clinic who were closed during different medical missions and were not thought through in that detailed manner, or were actually seen by some of the adult cardiologists who don't deal with that much of congenital heart disease.
Thank you. Those are really important comments. Dr. Apatowski and Sasikumar, do you have any additional comments on this issue of thinking about late presenting patients?
No, that is definitely still an issue, and in the United States as well. And in some sense, there's also more being identified later because of how much imaging and diagnostic testing we do now. Anomalous coronaries being an example of something that doesn't necessarily fit into any of these categories, but probably would be considered simple in that, whether true or not, if it's repaired, one thinks of it as cured. It's probably not quite true again. But I think that it is something that comes up quite frequently. Certainly less so though. So things like Eisenmenger syndrome are much less common than they were. And so there is a real distinction. I do think that it's really important to emphasize that saying someone has an atrial septal defect doesn't tell you very much. And the example of someone identified much later in life versus early in life, even without complications yet, is a great example of that Dr. Finn Thompson mentions.
Thank you. Dr.
Yeah.
Sisko.
Yeah, so in this part of the world, we in Kerala were fortunate that we had programs which were established, relatively earlier compared to the whole of the rest of the country. But I have to say that still in Kerala itself, we do see late presenters. Not only simple CHD, we have to say that we have CHDs of all complexities. The survivors, some of them do survive late, and we do have them present as adults. Tetralogy of fallow is again one of the commonest, where we have them present or come to us for the first time as an adult, not even having done anything in the past. Some of them have had one or two contacts with a congenital heart disease specialist as a child or an infant. But resources are a major issue, had been a very major issue in the past. Now, we are able to address it to some extent, but still we do have major challenges with resources. And then finally, when they become adults, some stimulus somewhere, they, and then they present as, okay, now we want to go ahead and fix this. And then, as Dr. Thompson was mentioning, the host of challenges that the operating team and the post-operative ICU team has to face when we consider them for surgery is vastly different from what it would be when we operate on them as an infant or a child. And yeah, I mean, how we overcome some of these, cyanotic congenital heart diseases who present later is like doing some form of a catheter palliation, which would improve their saturation and give them like 3 to 6 months of time so that all the, systemic issues related to the polycythemia and all settle to a certain extent, and then offer them the open heart. And that has, in our experience with that subset, it has helped quite a bit. So yeah, it is definitely a problem, and we need strategies to deal with the surgery and initial post-surgical care for these patients.
Thank you. I want to pivot now to thinking, actually going back to this question of communication and resources. One thing I wanted to stress, we obviously sort of frame this as about adult care, but we also know that in low resource settings, also in the US, actually, the large majority of people stop going back for care in childhood. And obviously, when you have a setting of an NGO or humanitarian care, that's just really, really hard. And then you have the added issue of the communication. So I have transposition. I'm a long-term complex congenital heart disease survivor. I know that, and Sasha stressed this in his comments, I had superb pediatric care, but my clinicians were really focused on making sure I thought I was normal and nobody worried about me. So the message I got is, you are normal, fine. Asked about having babies, yeah, go for it. In their mind, and I have had many conversations with pediatric cardiologists about that, people essentially were thinking, I'm not going to, I'll cross that bridge when we come to it, right? And of course, the challenge with that is that people get lost to care. And I am very lucky I'm here. I had a pregnancy that was poorly managed. In addition, I think that, this is especially true for the simple defects. And I have to say that the feedback we're getting, there are many leaders of patient family organizations here on the call. This is still a huge problem. This is still a huge problem. And I will say over and over that it doesn't matter if we have the best medical care, and it doesn't matter if we've developed some really good system. If people don't come back for it, it doesn't matter. And I'm the former head of the Adult Congenital Heart Association. I really want to be clear that in the US, at least, when what the clinician perception about this issue is that the parents were in denial or people weren't paying attention. When we surveyed the patients themselves who had been lost to care, when they were asked why didn't they come back, they said, I was told I was fine. I was told I was fine. I was dismissed from care, as we saw in Sasha's first example. So I would love to, again, pivot back to this question about communication. I'd love to start with Dr. Finn Thompson, because our experience in the patient community and family community is people think their surgeon is God, like truly. And what you say is what is very powerful. So how do you deal with this in your mission? And how do you, both in terms of making sure, not the adult, that kid keeps getting some kind of follow-up and that the communication is clear with families, particularly in a setting where there's not nursing care or a lot of bandwidth to do that communication?
Amy, I think that that's a really, really important question. And putting aside resource constrained centers, even here in our, kind of resource rich environment, I think this is, it's a little bit of, I think it's multifactorial. One, I think is, our field, if you really think about it, is still a relatively young field. We've been doing corrective heart surgery for just a little over 50 years. And I think that
But yeah.
doing them in a way that, we are no longer just thinking about mortality and getting kids through surgery and getting them to survive as the primary metric. I think we've moved well beyond that over the last 20 years, where I think post-operative mortality is no longer the accepted metric, but it's in fact the risk of complications, morbidity, and then morbidity-free survival. So our minds, I think, are shifting really to that, and I think it's taken a while to catch up with that. And I think when you transpose that into resource-constrained environments where people have access to care, but it's really sort of a one-time. Each mission has, I think most missions that go to resource-constrained places really only plan to operate and see a patient that has a corrective operation. So that's the one touch point you have. You can see how those patients might get lost to follow-up. So I don't have the solution other than to say that I do think that it requires groups like yours, I think patient advocate groups. I think that there is opportunities to educate adult cardiologists. The reality is that in most environments, there are likely to be, 4x the number of adult cardiologists that they are fellowship trained pediatric cardiologists. If there are ways to be able to educate them on how to anticipate and manage simple lesions in those patients, then some of these patients could follow up with them. So I think there are potentially a number of solutions, but I don't know that there's one solution that fits every environment.
Thank you. Other comments?
Yeah, I just want to make one small comment, is that also one of the biggest driver of getting care is finances. So in places that don't have, like for example, universal health coverage or a national level insurance system and out-of-pocket payment, many of the times just to get the patient to get their first surgery or any kind of intervention, you're trying to convince them and saying that, this is, get it done, it's going to give you a good quality of life, and this and this and this may be the only thing that you may need. Because the moment you start telling them, for example, if I start telling my top patients that, hey, you may end up getting a pulmonary valve replacement later on, you need yearly follow-ups, and with the yearly follow-up you need an echo and then MRI and all of those things, they start, and I've had that experience that I've actually lost some of those patients who just don't show up for the surgery then. So one has to, when it comes to that practicality on the ground, it's at times very challenging. And also stigmatization is a big issue. And in fact, some of the work that we have done around health-related quality of life, and KK's group has done some of that work also, one sees that there is quite a bit of stigma around congenital heart disease and corrective congenital heart disease, or correction or surgery or intervention around congenital heart disease, and how does one navigate all of that, also drives quite a bit of how the counseling and communication happens. So I think it's more of that whole developing that relationship and really figuring out some of those social determinants of health, because finances plays a huge role in how people seek healthcare in low to middle income countries.
Thank you. I will note that that's very true in the US too. We see huge health disparities in congenital heart disease. The one study showed that in the African American community, the average patient leaves before age 6. And again, I think that's, a real reflection of how people make these choices. Dr. Sasikumar, Dr. Apatowski, what are your thoughts on how we're going to solve this problem? Or thinking positively, how are we going to create a better model?
I just want to comment on one thing that you said, which I think is true, but I think we also have to give a little bit of, not the benefit of the doubt, but you were mentioning that a lot of patients had mentioned that they were told they were cured. And that, I think that is the case historically. I think that is much less the case now. Although still in some diagnoses, some places for sure. But the other aspect is communication is very hard. And we may know the 6 minutes that we spoke to a patient about that specific thing and know we explicitly said X or Y, but they speak to 15 people in a very stressful situation. And the number of touch points they have with all these different people is huge. And it may be, in anything, communication is very hard and misunderstanding is the norm. So I think that's part of why keeping people connected is important, just because you don't know what someone understands. Sometimes people come back a year later and will say something, and I'll say, that's not what I said. And then I think back and realize exactly what happened, and that I actually said exactly what they thought I said, meaning something entirely different. Now, that's partially my problem, but I do think it's for all of us that communication is difficult. In terms of how to make the system better, I think what Ms. Ross is mentioning in Canada, a program to try to bring people back into care, trying to keep track of who we've seen. In Boston, you all have an amazing resource of every single procedure you've done since the 1950s, I think, maybe 1940s even. I don't know that anyone's systematically gone back to the 1950s and 60s and called those patients and said, hey, what's going on with you? We don't have that luxury here. We have some of it, and we don't necessarily have it in our healthcare system overall. But as other places are doing this, starting to do this, this is a way to learn from our mistakes, maybe not Boston's mistakes, but everyone else's. And that is to keep track of who you're doing these procedures on, make sure that people in that community, if it's a mission, know who they are and how to be in touch every so often. We certainly don't do it well. We still don't do it well, to be fair. But that may be the lesson I would come out, because we don't have the resources to take care of these patients primarily for everyone.
Thank you, Sasha. I want to note that Bistra has her hand up, so I'm going to go to her and then circle back to some comments about this. Bistra.
Just wanted to point out that there are some comments and questions in the Q&A.
Great.
And so if you want to read them, Amy, or do you want me to read them?
No, absolutely. I wanted to follow up on something Sasha said, to note that there's an initiative in Canada called Find a CHD, trying to do exactly this. I should note that part of their focus, as I understand it, is actually on the ER level, not just primary care, but the emergency rooms, certainly, because that's where people tend to come back for care. And that sort of circles back to Dr. Sasikumar's comment about why can't we find these patients in the US. A lot of these patients come back, by definition, they're not in CHD care. So sort of thinking about where do we find the patients. And then Bistra, you have a question here. I should note there are comments from patients and family members about their experience of loss to care. But did you want to ask your own question there about?
Sure, yeah. I'll ask it. When we were writing the Global Burden of Disease paper, part of the modeling assumptions included some papers that were published that said that VSD patients, by the time they're about 40 or 50 years of age, their risk of mortality or risk of disease basically is almost equal to the general population. And I was wondering if you had any comments about that. Maybe Sasha would, or Navneeta would know.
say that one more time, that by the time they're in their 40s or 50s,
Yes, the
mortality
risk of,
same.
yeah, risk
Yeah.
of disease and mortality is almost similar to the general population.
I think that's probably not true. I think that it was probably, some of those papers are a bit misleading, I think. But I think that as the general population mortality goes up, though, the relative increase is probably less as well. So by the time you get to your 70s or 80s, even if it might be slightly higher, it may not be, you know, it might be a little bit. I think that I'm not sure what the papers are. We can go through them, but I don't think it's true. I don't know if Dr. Sasikumar.
I agree. I agree with that. Actually, there are papers from the Netherlands with very long-term follow-up after VSD closure, up till 40 years. I don't remember the exact numbers, but it was somewhere around 85 to 86%, something like that, like between 85 to 90%, 40-year survival. But those are patients who were operated between 1960 to 80, and they had issues on follow-up, including arrhythmias, ventricular dysfunction, like right and left ventricular dysfunction. And they even found an association between long-term, like ventricular dysfunction was around like 20% on this very long-term follow-up. And they even found a suggestion of association of ventricular dysfunction to the aortic cross-clamp time during surgery. I would agree that probably it may not be right to say that they're once they are like 30-40 years after the surgery, everything is similar. No, I do think that they are prone to some of the complications even late. And on top of that, we have the UK data, the UK biobank study data, which also shows that not only the CHD related long-term issues, they are for some reason at higher risk for like MI, stroke, and things like that. So as was mentioned in Dr. Opatowski's talk, they are at higher risk, but that doesn't mean that they are high risk. And communication is very tough because we have to maintain that balance of cautioning and not making the family panic, because most of them do well. So, and that too tailored to the understanding and the background of each family. So that I think is an art and will be different from setting to setting, patient to patient. And we not only us as care providers, I think all of you who are here, like the organizations who are involved in empowering the families, I think there is a lot of work that needs to be done in that way as well, so that there is somebody to reach out for them, even if they can't reach a care provider to ask such questions at any time. So I think everything counts in that aspect.
Thank you. We're at time, so I think that's a wonderful comment to end on. I really want to thank our presenters and Bistra for a very rich conversation, bringing up a lot of the challenges here and some thoughts about how we can really solve this problem and take advantage of this opportunity as new programs are being built, that are going to benefit from so much more data than we had in the rich countries when I was born in 1961. So thank you so much. This has been a huge honor. I will say thank you to all the participants. And I don't see a lot of questions in the Q&A that haven't been answered, but certainly you can type one in, or you can always contact Global Arch to follow up. And thank you so much. And we look forward to seeing you at our next webinar.